Hello, I'm Mary Beth Marsden. Thank you so much for joining us today for GBMC's Ask the Oncology Expert. And with this being Colon Cancer Awareness Month, we are particularly happy to have Dr. Joseph DiRocco joining us now live. He is the GI Oncology Program Director in the Sandra and Malcolm Berman Cancer Institute at GBMC, and he is, above all else, a colorectal surgeon. Thank you so much for being with us.
Thank you for having me, Mary.
And of course, you are just look forward to any opportunity to talk about this issue because it's still such a huge problem for Americans and worldwide, obviously. But people are still really struggling with recognizing the signs, living healthier lives to possibly avoid colorectal cancer. And we just want to know what the latest treatment is. And it's such an issue for so many people that I think more people have RSVP'd to this conversation than any of the other experts that have joined us. So everybody wants to know what you think. Thanks for being with us.
Again, thank you. So, I don't know, was a question about the latest in treatment for colon cancer, or we're going to get to
Yeah,
other questions?
let's just start with some questions because that's what I'm here for, right? So
Yeah.
let's just talk about where we are broadly with colorectal cancers. Is it still on the rise? Are people getting the message? Are screenings where they need to be? Just in broad terms, your view of where we are in this realm.
Yeah. So, with respect to screening and incidence, I mean, still colorectal cancer is the second most common cancer-related cause of death in this country and affects men and women nearly equally. And that means that 150,000 people are diagnosed with colorectal cancer every year. That incidence does not seem to be increasing overall as screening rates go up. But what we are seeing is an increase in younger people being diagnosed with colorectal cancer. And so those would be people under the age of 50. And so as a result, the number of organizations, including the American Cancer Society, changed their recommendations in terms of when people should start screening rather than starting at age 50, which was the historical start date for people who have no risk factors and no symptoms and are otherwise healthy. Shifting that back from age 50 to 45 to try to capture and hopefully prevent colon cancer in these younger populations. So that's one thing that's changed. There's also a number of other modalities or types of tests to look for colon cancer. But even with these additional tests, colonoscopy still remains the gold standard for colorectal cancer screening.
All right, we're going to talk about colonoscopy because I think there's a lot of preconceived notions about it. But I just was wondering, are there any theories as to why you're seeing these cancers in younger people?
You know, I mean, there can be theories, but nothing's been proven. There are some thought that there may be changes in diets or environmental factors that are responsible. The other possibility that we're learning more about, but is still in its real infancy, is looking at things like the microbiome or the types of bacteria we have in our intestinal tract. There may be some patterns of bacteria that we have that make people more predisposed to colorectal cancer. But again, there's nothing, no actionable advice I can give you on that front. But nonetheless, we are seeing it at earlier ages and have to take it seriously.
So the gold standard for screening is obviously the colonoscopy, right? Talk about where we are with that. Allay people's fears, if you will, who may be concerned about getting it or who just have been putting it off.
Yeah, so I mean, there's really no reason to put it off. The colonoscopy itself is painless, and most people have sedation for it, so you don't even experience any part of the colonoscopy. You're in and out of there. Typically, a colonoscopy takes less than a half of an hour, and there's really very minimal risk involved in a colonoscopy. It is a procedure. It's a diagnostic test that involves a procedure, so there is some risk to it, but it is still far more risky to not have a colonoscopy than to have one, because the benefits of a colonoscopy, not only in terms of early detection of colorectal cancer, but also prevention by removing precancerous growths called polyps. The advantages far outweigh the potential risk involved and the nuisance of going through the test.
And then, of course, depending on what is found or not found, you may not have to do it again for 10 more years, right?
That's right. So if you have no risk factors for colorectal cancer, you can get a colonoscopy every 10 years.
So when I talk with people, I don't necessarily hear that there's concerns about the actual procedure. It's the prep. We always hear about the
Mhm.
prep. Nobody wants to take the day off for the prep, and it sounds awful, and I can't eat, and da 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 da. Where are we now with that? I think it's way improved in the last even 10 years,
Yeah.
probably.
So there are more options for low volume prep. So the historic one of, it was called Go Lightly, which was a pun off of Breakfast at Tiffany's. But that was 4 liters of fluid that you had, essentially a gallon plus that you had to get down over the course of the evening before. And that was quite onerous for people to get through, often caused nausea in the process. And the point of all of these things is to give you a ton of diarrhea. So that way, when you come in for the procedure and we do the test, we can clearly see the inside of the colon. That's to be expected, and there's really no way around that with these oral mechanical preps. But in terms of what you have to put in your body to accomplish that, uh, as I said, there are a variety of different options, including low volume preps that include 2 small bottles where you would take one the night before and one the morning of the procedure. And there are pill preparations if people don't like drinking things. There are some of the preps have more flavor but lower volume. Some have less flavor but higher volume. And we also offer an additional option of people not drinking anything for the colonoscopy, just coming in and having essentially colonic lavage or a colon hydrotherapy and get flushed out from the bottom. Not everybody is interested in that, but there are additional options to even avoid drinking any prep for the procedure.
Okay, the last procedure you mentioned, and it's only because we were talking before the program began, you wanted to experience it yourself because I guess because if someone asked you about it, you would be able to speak firsthand about what it was like.
Well, I mean, I initially got interested in this because we have a number of people who have been unable to tolerate any preps. I have one woman with a strong family history of colorectal cancer, multiple first-degree relatives, and she had tried to take the oral preps and tried at least 3 different types and had intractable nausea just even thinking about it. So even though she desperately wanted to have a colonoscopy, she wasn't able to tolerate the oral prep to get cleaned out for the procedure. And at a conference, we saw these machines basically to provide low pressure, warm water enemas that could be administered by a trained professional. And so we work with a certified colonic hydrotherapist. And this provided another option. So for that particular patient, fortunately, when she came in and had her colonoscopy, we didn't even have a polyp, but nonetheless, she had been trying desperately for years to get this done, and this gave her the option. So when it came time for my own colonoscopy, I figured I would give it a shot as well because it seemed like more attractive and again, sort of curiosity to see what the process was like. And so I was quite pleased with the experience. It was very awkward, the first time around, but my second colonoscopy, it was nothing.
So would you go that route again?
Absolutely. Yeah.
Okay.
But it's, again, it's not for everybody. Just the thought of, somebody thinking that you're going to put a tube in their bottom and be awake for it is, very off-putting to a lot of people. And you mentioned that, not a lot of people are worried about the actual colonoscopy part, but there are a number of people who, won't want to get a colonoscopy or don't want to get a colonoscopy because of this fear of being violated or, or hurt in some manner. But it really is a very safe and gentle procedure.
While we're talking, people are writing in questions, and we've received questions ahead of time as well, and I really want to make an effort to get all of those in. But one of them, because we're talking about the colonoscopy, was about something called a Cologuard, and is that a replacement for colonoscopy?
That's correct. So that's one of the alternate testing that can be done. So typically a Cologuard is done every 3 years, and it has the advantage, the traditional stool test, looking for signs of blood in the stool, that has been improving over the years, but it still doesn't capture everybody and find everybody with colon cancer. And so the idea of the Cologuard is it not only does the normal test to look for traces of blood, but looks for gene products in the stool that may be indicative of an advanced polyp or cancer. And so if you do this Cologuard test and end up with a positive test, that would prompt you to get a colonoscopy. The test itself is, again, not as thorough or complete as a colonoscopy and can typically not identify most polyps, which, are precursors to cancer. So while it may be good at identifying cancers that already exist, doesn't do anything about prevention of colon cancer. And the other issue with it is that when people have a positive test, there's a fairly high false positive rate. So it creates a fair amount of anxiety in those people who have a positive test. They come in for the colonoscopy and we don't find anything. And usually in those people, I end up like looking back and forth 2 times because like, you have a test that says you may have cancer and here I'm telling you we can't find anything. It does create some anxiety, but certainly most
I
people
mean,
who have a Cologuard test have a negative test and they can sort of relax, and I'd rather have people do Cologuards than nothing at all.
okay, so it's better than nothing, but you're not particularly a fan of it.
Absolutely.
Okay, that makes
Yeah.
sense. We talked about age 45 being the magic number, the age at which we should all get screened for colon cancer, right?
Well, not all.
Okay.
So for people who have risk factors like a first-degree relative who's had colorectal cancer, you may start even earlier than age 45. And, as a rule of thumb, we typically recommend if you had a relative that was diagnosed with colon cancer, say at age 48, then they should start screening 10 years earlier. So essentially, that would be 38 for that patient.
What about a relative who's just had a lot of polyps or precancerous
Yeah,
issues?
so an advanced polyp would also be considered to be a positive family history.
Someone has written us and asked, is there a cutoff age? Is there an age at which you can stop getting screened?
Yeah, so I mean, routine screening is not typically recommended for people over the age of 80, but everything's individualized because there are, incredibly healthy people in their 80s who may have had a history of polyps. Your risk of colon cancer doesn't disappear once you get over a certain age. It actually continues to increase. So, but everything is a balancing act between, the stress and discomfort of, of having somebody go through a bowel preparation and come in and have sedation. What's what is the likelihood that we're actually going to find something to help them? So if somebody has had negative colonoscopies all through the years, we typically stop colonoscopy screening after the age of, after their 70s. But I have very healthy, fit people in their 90s who have had risk factors, and it's way easier to have a colonoscopy than to have colon surgery. I can assure you of that.
Let's talk about some of the other risk factors. People have a number of questions about that. One is about diverticulitis, and does that increase your risk of colon cancer? And then I guess at the same time, you might want to explain what diverticulitis is.
Yeah, certainly. So diverticular are little outpouchings on the colon. So if you have them, it's called diverticulosis. And the longer you live, the more likely you are to have this finding or condition. Most people, unless they had a colonoscopy or a CAT scan showing diverticulosis, would never have any symptoms or any risk from it. Diverticular disease does not turn into colorectal cancer, but what these little outpouchings can do is sometimes they can cause painless bleeding, which can be fairly dramatic, but fortunately, it usually stops on its own. The more common thing that happens is one of these little pockets can burst, causing an infection in the area of the colon. And that's what's called diverticulitis. And there's a big spectrum of, mild diverticulitis where people have some little crampy pains down, typically in the left lower side, but can be other places. Maybe fever, chills, and a change in their bowel habits. Typically responds to antibiotics and bowel rest, and sometimes people need hospitalization or even surgery for it. But diverticulitis itself doesn't predispose people to colorectal cancer. Now, sometimes when people come in and they've had an episode of diverticulitis, we recommend a colonoscopy as a follow-up for that. If they haven't had one in the past, 2 or 3 years. There's not strong evidence, but the idea is that sometimes colon cancer can perforate and can mask as diverticulitis. And so the reason to do a colonoscopy in that setting is just to make sure that that's all we're dealing with, that we're not dealing with anything more serious like a perforated cancer that would need more urgent treatment.
What about the risk factors for the individuals with Crohn's or colitis?
Yeah, so people who have had inflammatory bowel disease that affects their colon, over time, the longer that inflammation is there, it can predispose to developing something called dysplasia. Dysplasia just means cells that are growing abnormally. And so cancer is a form of dysplasia. And so the dysplasia can be characterized as low-grade dysplasia, high-grade dysplasia, which is more or less cancer-looking cells. And we only call something cancer if those cells are in a deeper layer in the intestine. So once somebody has had colitis for over 10 years, the risk of them developing this dysplasia and ultimately cancer starts to increase. And so those people the recommendation is to do a colonoscopy every 2 years with some variation on the recommendation in terms of, the physician's practice patterns and what their individual risks are. So, and when we do those colonoscopies, sometimes we use special visualization to try to find these areas of dysplasia. And sometimes we take just random biopsies throughout the colon, looking for signs of dysplasia, because it can be quite difficult to identify in these patients, especially if they have a fair amount of inflammation just from their inflammatory bowel disease. And if we do find this dysplasia, oftentimes that's a trigger for having major surgery, because people with colitis who develop cancer tend to do much more poorly than people who don't have colitis. So we tend to be a little more aggressive.
What about for the person who doesn't have, let's say, a pre-existing condition, and they're doing the early screening with colonoscopies, which is the best way for early detection at this point? What are some of the other signs and symptoms that we all need to be on the lookout for that could indicate a problem?
So any change in your bowel habits, onset of rectal bleeding is another one. Sometimes if there's some blockage, people get abdominal distension and cramping. In some cases, if that proceeds, they can even develop nausea or vomiting. But most of the time when we detect cancers, people have no symptoms whatsoever. They're found during screening colonoscopies. So that just stresses the importance of pursuing screening colonoscopies. Sorry about that.
You're a busy man, I know. Also, people have asked too, what can they do? We've talked a lot about healthy living and just avoiding cancer in general, and that is, keep your weight manageable, don't smoke, eat well. But are there certain things that trigger or could trigger colon cancer that we may be doing in our everyday lives that we should avoid or rethink?
So, and the things that have been proven to increase the risk of colorectal cancer are some of the things you already mentioned. Smoking and drinking certainly increase the risk of cancer. And consumption of processed meats, things like hot dogs and cold cuts, et cetera. Those have also been demonstrated to increase the risk of developing colorectal cancer by, over 18%. So, minimizing that, increasing dietary fiber, all that leads to decreased likelihood of developing polyps and ultimately cancer. But certainly, I wouldn't trade a lifetime of healthy eating over a screening colonoscopy.
Okay.
So, just
it's
because
another
you
tool
do
in the
everything,
toolkit.
just because you do everything right doesn't mean that, that you're immune from developing colorectal cancer.
So
even Dr. Oz had a polyp.
We talked
And
a
just
lot
ask
about,
him if he does
that's,
everything right.
and asking about polyps, someone also asked about whether or not the polyps would necessarily always be removed if they're discovered during a colonoscopy.
So the answer is yes. Sometimes we cannot remove a polyp because of its size or location. Some polyps can be potentially dangerous to try to remove because the colon wall is quite thin, and if it's in a dangerous area and has a difficult location, There are situations in which patients who have had a colonoscopy, had a polyp, it would be biopsy just to make sure that we have a good idea what kind of polyp it is. And in some cases, people get referred to me for surgery to remove the polyp, in a more advanced way, not with a colonoscopy. Sometimes we can use advanced colonoscopy techniques to remove these difficult polyps. But those are the minority of situations. Most polyps that are identified during a colonoscopy can be safely removed at the time and sent off to the pathologist so they can look at everything after it's fixed under the microscope and tell us exactly what's going on. There are some polyps that people typically have at the end of the colon. They're called hyperplastic polyps, and those are not considered to be precancerous. So if we see, and sometimes people have a dozen or more than 20 of these types of polyps, if we see those, we typically just take a sample of, around 3 to 5 of them just to make sure that we know what we're dealing with and leave the rest of the polyps there. But that's also, an unusual situation.
In most cases, if someone is diagnosed with colon cancer, is surgery involved?
So for colon cancer, if there is any potential for curative treatment, meaning, the goal is to be a survivor of colon cancer, then surgery definitely plays a role. There's, no other therapies such as chemotherapy or radiation or anything that can be done through the scope that, through the colonoscope that can avoid colon surgery in those patients. And having a colon surgery for an early stage colon cancer, has very good prognosis. So for a stage 1 colon cancer, the likelihood of making it 5 years without any recurrent disease is over 90%.
Someone had asked, is there a new cocktail for colorectal treatment? I'm sure there's always new things happening, right?
Yeah, I'm not sure.
What they mean by that.
We don't recommend alcohol for treatment of colorectal cancer.
I don't think they mean
that's
that.
if they're referring to different chemotherapy regimens,
Yeah.
there are new immunotherapies and regimens that are customized, from patient to patient. I'm not a medical oncologist. I'm a colorectal surgeon, so I don't really want to speak outside my particular area of expertise. But we have ongoing clinical trials for a different immunotherapy that can be added in addition to chemotherapy, and the treatment is constantly evolving. Some of those things are just available for people with particular types of colon cancer. So it really depends what the biopsy shows and what your particular situation is.
Do all surgeries lead to a colostomy?
Thankfully, no. Most surgeries that we do electively, when when it's planned and they come in for surgery, rather than on an emergency basis where people either have a complete blockage or infection, etc. Almost all of colorectal surgery does not result in a colostomy or ileostomy. The treatment of rectal cancer, especially if it's locally advanced, oftentimes involves a temporary ostomy, typically an ileostomy, which is a portion of the small bowel. And that's just left in place until things heal up and then we get rid of it. And that usually marks the end of their treatment. But the answer is no. Most elective surgery, does not result in a planned ostomy.
Because we talked about the fear that people have of the screening. This is another fear I think that
Right.
people have.
Yeah, and if that's their fear, then they should use that fear to go and get a colonoscopy, because early detection and prevention is your safest guard against of needing an ostomy at any point in your life. As I said before, it is way easier to have a colonoscopy than to have colon surgery.
A couple more of these questions, and we've touched on some of this, but I want to make sure we get to some of these specifically. Someone asked the difference between a polyp and a hemorrhoid.
So, so a polyp is a growth on the lining of the colon or rectum. People can get polyps in their nose anywhere in their intestinal or airway tracts. Polyp is just a little growth in the airway or in the intestinal tract. And what it is an overgrowth of the cells that line the colon. So these cells are constantly dying and regenerating as you continue to live. And sometimes the signal to this regrowth gets screwed up in the process, and cells tend to heap and create a little mound or a mass. And that's what a polyp is. As I mentioned before, most polyps are precancerous in the colon, but some are not. A polyp, by definition, is not an invasive cancer. And, and then by contrast, a hemorrhoid are blood vessels under the skin near the anus. And people can have internal hemorrhoids, external hemorrhoids. They are an area of protrusion but it's not an abnormal growth. It's from dilated or swollen blood vessels under the surface.
You said at one point that you shouldn't just assume that you have a hemorrhoid, but let's say you have a history of hemorrhoids and you think it's a hemorrhoid. At what point should you say to yourself, this isn't healing? After what period of time should you get checked further?
So, I mean, anybody with rectal bleeding should get checked out. Now, if you just have maybe you're straining or have an episode of like the runs where you're having frequent loose stools and you end up with a little bit of bleeding that day that then resolves, probably it's from hemorrhoids, but if anything becomes a chronic symptom where it recurs, or even if it occurs one time but it's significant enough, it doesn't hurt to come and get checked out, because it's way more dangerous to just assume that everything is okay than to have an evaluation. And not everybody with bleeding that comes in do we recommend, screening by colonoscopy or anything extreme like that. But nonetheless, leave it to the professionals.
How concerned were you during this period of the pandemic, particularly in the beginning when people weren't comfortable going to doctors? They couldn't go to doctors, but they weren't comfortable going to the hospital, even if maybe they needed to. I would imagine that a number of people who had planned to maybe get screened or had planned to get something checked out did not and put it off.
Yeah, it's hard to know without population data, but I mean, this winter and fall, we've been seeing, a lot more people with advanced colorectal cancer. Whether that's just, my impression or that's a result of screenings got, markedly reduced during this pandemic. And I still have patients that are very reluctant to have screening colonoscopies or surveillance colonoscopies at this point. So, it'll take time for people to catch up, but we were already at lower screening rates than we ought to be even before this started. And so it's just going to compound the problem. But hopefully, once everybody feels more comfortable engaging with the medical system in person, we'll get screening rates up. But I mean, I have to imagine that, some of what we've seen this winter is, as a result of that.
Someone wants to know, what is the current survivorship rate of patients being diagnosed and receiving rectal surgery?
So, I mean, that is highly dependent on stage. And so some of that stage for rectal cancer, we can tell before they undergo treatment. We have special MRIs that we do for patients, every patient with rectal cancer, to try to assess the stage, and that will help determine what kind of treatments they need, and also their prognosis. The issue with rectal cancer is, the way to really stage something is to take it out and have the pathologist look at it. And oftentimes with rectal cancer, they've already undergone treatment, either chemoradiation or some variant of that, before they even come and have surgery. Nonetheless, for early stage rectal cancer, if it's very early, a lot of times we don't even need to do what we call major surgery. We can just remove the tumor, sort of like a super colonoscopy, from inside of the rectum and just remove the area where the tumor is. But for more advanced cases, people need to undergo chemoradiation followed by surgery, sometimes followed by more chemotherapy. And again, exactly what the 5-year survival is depends on what stage it is, and so it varies significantly from from early stage to more advanced stage cancers.
We have a question here about laxatives. Is it okay to take them regularly for constipation? What are the side effects of these drugs? And is there anything else we should be looking out for when going to the restroom?
Well,
You
I
mentioned
mean,
bleeding.
there are that is a fairly comprehensive question. So, I mean, um, any regular laxative usage should be discussed with either your primary care physician, or if you are struggling with constipation and feel like you're dependent on laxatives, or still having issues despite regular laxative usage, you should see somebody either in our gastroenterology department or one of the colorectal surgeons here at GBMC. It's certainly something that we all manage. Laxatives have a variety of different mechanisms of action. So some laxatives you really want to avoid using long term. Things, especially things that are stimulant laxatives, because essentially you turn your colon into a crack addict, and it demands that stimulation in order to work. So not all laxatives are safe to take. There are a variety of laxatives, some prescribed, some over the counter, that are safe to take long term. But in general, an easy recommendation, if you don't want to see your doctor, is you can start with fiber and increasing your daily fluid intake. And that's non-caffeinated fluids. So, if you do that, that straightens out, honestly, most people. Nobody really likes to take fiber because the powder is, you know, um, not easy to to tolerate for some people. You have to drink a lot of liquids with that, but there are a variety of different forms for fiber, even fiber gummies,
Yeah.
capsules, tablets. So there's really no reason not to try that first. And fiber is safe to take your entire life.
Yeah, hugely important. This is a very
Yeah.
specific question, but
Especially with our Western diet that
yeah,
tends to be relatively low in fiber.
absolutely, absolutely. This question does raise an interesting issue. This person's mother had numerous colonoscopies and died at age 78 from colon cancer. Her doctor said the cancer was in an area that a colonoscopy does not show. Are there some of these shaded areas or dark areas or areas that are hard to see in a colonoscopy?
There definitely are areas that are hard to see, and so I haven't seen a large number of patients who have had a colonoscopy and then are diagnosed with cancer shortly thereafter. But I have two people that come to mind, and both of those patients had cancers in what are called the flexures, and a flexure is where the colon makes a turn. The colon's sort of like a question mark, starting down by the anus and wrapping all the way around the abdomen. And so where it makes the turns on the two top corners, sometimes things can be overlooked there. But a complete colonoscopy should look at the entire colon and rectum. There shouldn't be any places that it can't reach. Now, sometimes people are diagnosed with anal cancer who have had a normal colonoscopy, and sometimes anal cancers can be quite subtle, and can be missed during a colonoscopy just because it's not an area you see with the camera. It's an area that you would have to feel with your finger, and sometimes it can be tricky to pick up on that. Or it could be in another portion of the intestine, not in the colon or rectum, where the colonoscopy wouldn't normally reach. But there are places that are perhaps difficult to look at, but there shouldn't be any place that where a colonoscopy doesn't examine. It's also possible, without knowing the particulars, there might have been, a blockage or a twist where they couldn't complete the colonoscopy on this, patient, and so for that particular person, there was a place where the colonoscopy couldn't reach, or they weren't cleaned out, adequately for the procedures. I'm not, without knowing more details, it's a
Right,
little difficult
right.
to answer.
Dr.
But a
DiRocco,
colonoscopy should look at every nook and cranny.
and while we're talking about that, I just want to give you one more opportunity with the time that we have left to make just another pitch for screening, and how life-saving it is for so many people. Just the age at which we should, how this, even racially, how it breaks down with who should be really more aware than others at certain times in their lives.
Yeah. Well, I mean, certainly incidence of colorectal cancer and how advanced the disease is at the time of diagnosis is higher, particularly for Black males. Um, w- Screening rates in the population are also lower. So the question is it, is it that doctors aren't recommending it to patients, or are they having difficulty accessing, physicians to come in and get appointments and get screened? I mean, we want all of God's people to get colonoscopies. So,
Okay.
the recommendations right now are equal for everybody. Start at age 45, every 10 years with no history. And especially if you have a first degree relative, you know, ask your doctor about screening because it's starting at age 40 or 10 years before the earliest age of diagnosis.
Dr. Joseph DiRocco, is always a pleasure. Thank you so much for being with us today. And thanks to everyone for joining us on GBMC's Ask the Oncology Expert. We'll see you next time.